grand occasion today. A distinguished group of visitors. This is usually run by the chief residents, and I'm here just to stand in a bit for Dr. Cohen, who unfortunately had a very impressive prior commitment and could not be here. Let me introduce our chief resident, Dr. Efron.
Thank you, Dr. Bush. Just a few practical points. Than the usual conference, probably till about 1:30. So to keep things orderly, we'll pause as close as possible to 1 o'clock and ask that those of you who need to leave wait till then. We'd also ask that if you need to answer pages, you go out the back door and follow the signs to Dr. Levin's office, which is quite a task. We'd also like to thank the library staff for setting up a display of some of the original works related to the Cocoanut Grove fire in the back. And after the conference, we'd like to invite you all to a reception where you can meet informally with the speakers. And now I'm pleased to introduce Dr. Steve Spar, who completed his internal medicine residency here a few years ago and gave his senior resident lecture on the Cocoanut Grove fire. Became very interested in it and did extensive research at that time. He is now chief resident in neurology at Albert Einstein, and he will coordinate the rest of the conference. I want to thank him very much for the monumental effort that he's made in organizing this for all of us.
I'd like to start off by reading a little article that appeared in the Dartmouth College Alumni magazine a few years ago. Can you all hear me first of all? Can you hear me in the back? It says, when Charles A. Collins made his landmark pledge of $5 million to the campaign for Dartmouth, he requested that $100,000 be set aside to honor a classmate and former football star who died tragically in 1942, shortly after receiving a degree in medicine from Harvard Medical School. The classmate was Gordon P. Bennett. Dr. Bennett was a victim of the Cocoanut Grove fire in downtown Boston in 1942. He was credited with saving the life of his fiancée by shielding her from the flames with his own body. He failed to survive emergency surgery at Boston City Hospital, the hospital in which he had just completed his internship. The date was November 28, 1942. A fire erupted in a basement bar of Boston's popular Cocoanut Grove nightclub and spread rapidly across the ornate decorative materials. Panic and confusion ensued as many of the exit doors were locked or concealed. Within a 15-minute period, the entire nightclub was ablaze. The victims, injured, dead, and dying, were ferried to various Boston hospitals, with Massachusetts General and Boston City receiving 95% of the victims. In a ragtag convoy of ambulances and taxi cabs, commandeered railway express trucks. Soon, the emergency rooms were inundated. At Mass General, 114 patients were received in less than 2 hours, 39 of them alive. At Boston City, the figures were even more staggering. Over 350 victims arrived at the accident floor in less than 2 hours. They calculated that a new patient was received every 11 seconds. For the first time in the hospital's history, the male-female segregation of the accident floor was suspended as the line of dead and injured piled back out of the Dowling building and on into Albany Street. Dr. Melvin Lyons, who was formerly a BU medical student at that time and currently the head of urology at Malden Hospital, was at the accident floor that day, and he described the horror of the situation. He said that bodies were stacked as cordwood, and many of the victims were so charred that it was impossible to assess vital signs or establish intravenous access. Dr. Lyons went on subsequently to serve in the armed forces and was part of the group that liberated Auschwitz. And he said that his revulsion that evening was comparable to his experiences in Europe. And yet, in the wake of this profound tragedy, more was learned about the management of burns and their complications than in any civilian experience before or since. Before we meet today's speakers, I'd like to be allowed just a personal digression of how I became involved in this project. 3 years ago, when I was a senior medical resident, I went to the library to look up a book by Dr. Alan Cohen, a rheumatology book. And as I went through the card catalog under the CO section, my finger caught upon a card that said, in bold, typewritten letters on the top, Cocoanut Grove Fire, collected papers. And in pencil across the face of the card, in the closet. I spoke to Margie Dempsey, who had just come on as our new librarian, and when I asked her about this, she said, those closets haven't been sorted through in 20 years, but she would make an attempt to try to find it for me. 2 weeks later, I returned, and Margie presented me with this cardboard box that was so dirty that just handling it, my hands turned black. Inside the box, can I have the first slide, please?
You gotta put that next slide. Full screen. Watch the picture. Next one.
Inside the box, I found 20 to 25 papers published by the physicians who cared for the Cocoanut Grove victims. And as I skimmed through these papers, I was struck by two aspects. The first aspect was the literary style, which was much more descriptive and in some ways more lyrical than papers you see in current day journals. And in addition to large amounts of descriptive material, I began to see attempts at quantifying illness, and maybe for the first time understanding physiological principles behind burn injuries, respiratory wounds, etc. In short, it was as if I was witnessing the birth of the modern medical era through those papers. The second thing that struck me about this collection was the richness of the content. There were descriptions of treatment of surface burns, pulmonary complications and their pathogenesis. There was Ham's work on osmotic fragility in the red blood cells of the burn victims. There was description of one of the first uses of positive expiratory pressure, and the first civilian use of penicillin, the first use of intravenous albumin. There were also papers describing the psychiatric complications, and one very fascinating neurological complication, which I will get to later on. I wanted to know more, and so I spent much of the rest of my residency, the 9 months that were left, completing the collection of Cocoanut Grove papers, interviewing physicians who were around at that time. I used any excuse to talk to patients who looked like they were old enough to remember what was going on. And I became involved in a project of finding and following up this interesting neurological patient with the assistance of Frank Drislane, Milton J., and Dr. Bennett. And I discovered, the next slide please, a very interesting and well-documented book by Paul Benziquin, the radio show host, Fire in Boston's Cocoanut Grove, and subsequently we've had a second book come out recently by Edward Keyes, author of the French Connection, who I invited to come today, which was in Los Angeles right now. Both very well documented, beautiful works describing some of the background of the fire. I even went so far as to go across to the accident floor to find Willie Regan. I don't know if anybody Willie Regan used to be I think he used to be an orderly in the hospital, and now he's sort of, that's right, a hanger-on in the emergency room.
He never had a salary.
I brought him up to the second floor of the ACC and brought him a cup of coffee. I said, Willie, were you here the night of the Cocoanut Grove fire? And he said to me, that I was, laddie. The devil walked that night. I said, well, I pressed him for some more details. To which he replied, the the devil walked that night and he carried his pitchfork. When I moved on to Albert Einstein, I ran into Stanley Levinson, and he was hoping to be here, hoping he wasn't delayed by the weather. He is the head of the burn unit at Cocoanut Grove, and was one of the authors of the papers of the Cocoanut Grove experience. And in our frequent conversations, we decided that it might be of interest to once again, after 43 years, reconvene this group of men who published the papers of the Cocoanut Grove experience, who were clinicians at the time. So 3 years later, the names out of that dusty box appeared before you right now. And I think it may come as a surprise to you, and after 43 years, this is truly a vigorous group of people still at the peaks of their careers and still going strong. Two names, however, from the list deserve our special attention. And if I can have the next slide, please. The first one is Dr. Charles Lund, who was the head of what's called the burn assignment at Boston City Hospital. He was working on a federal contract to study burns as part of the war effort, and he sort of coordinated and provided leadership from the surgical point of view. The other name, I think, is familiar to all of you, and if you have the next slide, please. It's that of Dr. Maxwell Finland, who served as head of the Harvard Medical Service at Boston City at the time, and he took personal responsibility for supervising the management of the medical complications of the Cocoanut Grove affair. When I say personal responsibility, I'm not talking about delegated responsibility. Dr. Finland personally examined each patient, all 131 at the beginning, every day. These patients were spread through 8 buildings, 22 different wards. I think someone had calculated that one route was around 4 or 5 miles. And often he rounded on them twice. There's a third name, not from this institution, but who performed the analogous function at Massachusetts General, and we're very honored to have him today. That is Dr. Oliver Cope. And just to conclude, on November 28, 1985, exactly 43 years after the Cocoanut Grove experience, the New England Journal published a review of burns. And in that article, they mentioned that some burn centers are reporting less than 10% mortality for burn victims who have second and third degree burns covering 50% of the body. Less than 10%. In 1942, that mortality figure was very close to 100%. The difference between the mortality figures we see today and those of 1942 is in no way, no small way, due to the efforts of the men that you see sitting before you. And I think we will begin by just briefly mentioning the names of our panelists. Dr. Levinson, who is on his way, hopefully up from New York, will provide a more detailed biography of each of these men. But let me introduce you in order of the presentation. The first speaker will be Dr. John J. Byrne, currently head of surgery at Birmingham Hospital. George Cruz, who is Dr. Oliver Cope from Mass General. Dr. Charles Davidson, who after leaving here went on to work at MIT and Harvard Medical School. And finally, Dr. Levinson, who hopefully will arrive soon. The first speaker will be Dr. John Byrne, who will provide an overview of the events of the fire. Thank you.
Thank you. Do I have the next set of slides? Yes, sir.
Dr. Levinson saying?
Lights out, so it doesn't fall down. He's low and I.
We have an our slug here is fighting for us here.
How are you, Stan? I see, yeah.
Careful there. Well, speaks over the place.
How are you? Good.
Well, actually, in 1942, we were not as devoid of scientific knowledge as the last speaker. This is the city hospital at that time. I can't get this to work too well. It's so late. The Dowling building here, of course, where the emergency room was, and where most of the victims came in for the entrance. That's a lot next to it. Approximately that level is where the malaria palace used to be, and there was a green grass in between here that was used to stack up the bodies. The living patients were scattered all over the hospital. The lung burns went to medical services, and the skin burns went to surgical services. Then there were 5 surgical services. The 3rd and 4th surgical services were over here in the surgery building, and the 1st, 2nd, and 5th surgical services were in the Dowling building. Over in here, you can't quite see it. It's the wards A, B, C, D. One of those, at least, was a training ward for nurses where they taught them how to make up beds and things. And that was a 30-bed unit, which was always intact. And below it, there was another ward, which was available for emergency. The war was on. There were commanders. We had posts of the Army, the Navy, the Air Force, the Marines, and the Coast Guard in Boston. So probably 500,000 to 750,000 troops in Boston. We were ready for disaster. There was stockpiling of material, there was stockpiling of gauzes. All the windows and all the roofs and all the ceilings were all blacked out. As I said, we weren't devoid of scientific theory. We were very fortunate to have many people who knew quite a bit about burns, because we had treated a lot of burns up to that time. The mortality was not close to 100%. We were very privileged to have a man by the name of Bob Aldrich with us. Aldrich graduated from Princeton, and he went to Johns Hopkins, and he worked with Dr. Farwell. And in the 30s, he and Farwell came out with some magnificent papers on the role of infection in burns and how to prevent it. And he worked on a series of aniline dyes, which they treated the burn with. At the same time, there was a great feeling that there was a tremendous plasma loss from burn. It was thought there was out to the burn, and some people brought in the tanic acid solution, which would char the burn so you wouldn't lose your plasma. It wasn't later on until fine work by Dr. Cocoanut that showed that the plasma was being lost in other places. There was an emphasis that infection was important and that plasma loss was important. Because of the disaster, there was a storage of plasma in the Harvard Surgical Research Center. There was the Roman Mallory building, and Dr. Maddox was in charge of this plasma. On the night of November the 28th, as he mentioned, things were pretty quiet in Boston. There was a football game. Boston College was going to go to the Orange Bowl after the beat Holy Cross, and the house also weren't doing very much. That evening, there was a big, we didn't work as hard those days. Over in the Boats House, which is this building here, that evening there was a large party arranged for the Nurses Alumni Association. So 50 or 60 or 70 nurses were available at the night of that particular episode. I can't get much more out of this picture. But about 4 o'clock in the afternoon, the Orange Bowl team left the football field of Boston College because Holy Cross was whipping about 55-2, and they were not going to get a goal bid. The Boston College football team was going to go to the Nightclub in Boston called the Cocoanut Grove. They canceled out their appointments because they were so rejected by the entire thing. Many other people, however, went to the game, went to the Cocoanut Grove after. Next slide. This is just a chart. It doesn't show. This is from Aldrich's book. It was as far as I'm concerned, maybe the first
1870 to 1880. And then how with the animal diet, mortality got down to about 5 or 6%. Rose again with the use of panic acid, and fell again as the animal diets had more use. This was a magnificent monograph. All the details of burns, treatment, surface of burn, in fact, with all infections, use of plasma, and all that sort of thing. Next slide. Now, this is Dr. Lund, whom we're on today, along with Dr. Finland. More familiar with Dr. Lund's story, since he was one time he was assistant chief of the Third Surgical Service when I was here. He eventually became head of the Fifth Surgical Service. He was one of the scientific surgeons at our hospital, one of the few, and he was in on burns, on plasma usage, and he was the head of the unit of the grants supplied by the War Council to study burns. And about 10 o'clock that night, he was called in by Dr. Manera. Dr. Manera was the superintendent of this hospital. It was a time when the hospital had one administrator. He's now straight into the current generation. But he was the administrator of all things, personnel officer, everything. And he and Win O'Connell, the night executive, walked out the door of the city hospital. And there was an alcoholic in there with a burn. They called Dr. Lund in to treat him. So as Dr. Lund was coming in one door with a bag of plasma, treat this victim, the first victim from the Cocoanut Grove, arrived. So a lot of things happened together to bring people together, material together. So what happened 40 years ago couldn't possibly happen today. They had 5 burns a couple of years ago down in Norwood. They couldn't get them placed in Boston. This particular thing, we had 129 at the city hospital, 39 at the Mass General, 500 or 600 people, 500 or 600 bodies, of course, which were all taken care of in a pretty orderly fashion, considering our next slide. It was wartime, and the movie stars were in Boston trying to drum up interest and help boost morale. This is Buck Jones, the cowboy star, and he was at the Children's Hospital that afternoon seeing patients. Seeing the patients over there, trying to cheer them up. And he went to the Coconut Grove that night for a little relaxation. Next slide. A lot of musical shows, again bolstering morale. This is the Army show, which was in Boston at the time, and they had their dinner at the Coconut Grove Fire about 4 o'clock because they wanted to get ready for the evening show. And this picture was taken with Mickey Alpert, who was the musical director or the band leader at the Coconut Grove. He survived the fire. Next slide. There was just about the time the fire started, there were pictures now. The girls go around and take pictures, and this young lady had taken a roll of pictures, and then she knew that when the dancing started that Walensky didn't like anyone in the taking pictures, so she then went out to have her pictures developed out in the store. That's how she survived the fire, because shortly thereafter the fire started. But her pictures were developed, and these are people sitting at the Coconut Grove, and these are all from Benson's book. These are people sitting at the Coconut Grove the night before, maybe a half hour before the fire. Next slide. A lot of them there on the side of those examples. This is the bartender, William Shea, big heavy fellow. He was at this is the Melody Lounge. This is downstairs in the Coconut Grove, and it's the picture taken a couple of days before the fire. Next slide. Now the fire started. You see now where the whole building is engulfed. Flames coming out the windows. This took place in 5 minutes. This is 5 minutes after the beginning of the fire. Next slide. You can see why so few people escaped. Here's the floor plan of the Coconut Grove. It was over on Piedmont Street. This is right next to the Howard Johnson site. This is right here down. There's a big parking garage here. The features of the Coconut Grove are the Melody Lounge, or this was right here. That was underground. It was the first floor down. And that was supposed to seat about a couple hundred people. And the night of the fire, about 500 were jammed down in this lounge. The stairs you can see on the right-hand side where the exit up. And over in the left-hand corner, better pointer. Next
You put it forward.
Hold the hands a little This is the Melody Lounge. Over this corner there was a coconut tree, a false coconut tree. The light on it went out because there was a couple here that was sparking a little bit, and they didn't want to see it. right back in the ball and walked away, put the match out. In about 5 minutes, the flame started here. We now have a closed off area with nothing. The only oxygen in this place is what's already existing. There's a fan blowing up here. And this fire started here, flammable draperies, leatherette type of false leather things, and it just blew like, incidentally, later on when they studied the fire, that had been inspected by a fire inspector about 2 weeks before the fire. And he lit a match to the palm tree and it didn't light. So he assumed everything was all right. Some smart guy from Harvard said, you ought to take into account the humidity. And they had studies of the humidity figures of every single day. And on a dry day, which November the 28th was, this stuff was flammable. On a moist day, it was not flammable. So it's just that little freak. And since then, they have to take care of humidity when they're doing flame testing. So a fire started here, and the people here, of course, started, almost 300 or 400 people down here, started to rush up the stairs. Before any of them got halfway up the stairs, the fireball had reached up the stairs and got the ball, took all the oxygen out of the room, so they died of asphyxiation or chemical burn. They came out this way, the few that lived, they couldn't get out here. Then they met this group over here that saw the fire. The fireball out here. 5 minutes is all it took for that fireball to start from the basement, sweep through the building, and make its way out here. They don't know quite how it. This fan here had something to do with it. It was exhausting the air, so the fire sort of raced out that way trying to get oxygen. Couldn't get any oxygen this way or not this way, and finally got these windows out the door. And finally, some holes were made and the fire was allowed out. So now we have people stacked up here. Everybody trying to get out the revolving doors. You know what's going to happen there. They jammed there. The first 2 people got out, and they jammed up on both sides of the door. People trying to get out this door, trying to get out the windows and couldn't get out. A few people escaped through these little side doors, and if you knew your way, such as the waiters did, there were doors, say, from Melody Lounge down to the kitchen, which is nothing here, and they can get out through this window. A few people got out that way. A lot of waiters did their best to try to get people into these exits. But basically, you see, there were no exits. And even the exits that were going to be blocked and no time at all. So it's no wonder that you have the next slide. Well, after 5 minutes, this is 5 minutes all it took to kill 500 people. They had to try to get the victims out. They got them out with Dr. Spar mentioned all kinds of ways, different taxis. In those days, when you're injured in Boston, you came to the city hospital. I see Earl Wilkins here and people like that who were the Mass General when I was here in the city. And we got all the trouble. You could break your hip in front of the Mass General and the taxi would be also, the city hospital owned all the ambulances. So everybody was where you're injured came to our place. This is why you like to intern to go to the city hospital those days. If you're interested in trauma, you got it here.
Jack, where up that hay on windshield?
What's that? Oh, yes. That was the gasoline.
That was the gasoline ration.
I meant you could have so much gasoline a week for a month that you got tickets. So this is obviously a private car, that's not a taxi. And they all came to the city hospital. When Mary was down there, and the bodies were first brought into the little cubby holes and on both sides of the bridge. Pretty soon you realized they were bringing in dead people. And then he went outside and showed the doctor. By that time, the staff was coming in. Doctors were coming in from all over the city. Nurses coming in from all over the city and so forth to help. And he then finally did triaging outside the Dowling building. They got the dead bodies out, mostly on the lawn or over to the southern mortuary, which is across the street. And it's in one of those piles of dead bodies is where the bed was found, which was talked about. An orderly saw the charred body out there, so that's not prevented. They brought it back into the hospital and we started treating. Next slide. Here the Coast Guard bringing people out of the building to see the terror in the United States. Next slide. More people. Here's the dead body being brought out by firemen. Every fireman in Boston, all the surrounding areas were now surrounding the Cocoanut Grove with putting out the fire. Didn't take long to put out because it was not a real fire. It was a fireball that went through the building. The building was still intact. The floors were intact. The wood was charred but wasn't burned through. The roof was intact. Next slide. Next slide. This is a more, see that now they've broken down some of the windows and are carrying the bodies up, all the windows down into the street. This is on Piedmont Street. Okay. No, this would be on Shawn Avenue. These are the windows on Shawn Avenue. Next slide. Next slide. The southern mortuary was set up for take care of it. There were 2 mortuaries in Boston. And the southern mortuary, which was the Mauer building, the northern mortuary, which was down in Massachusetts General. And the dead from both sides of those mortuaries. Obviously, if you've ever been in this building, you know the whole 500 people or 400 people. So they had them stacked up on the roof. They evening dress on, her lipstick was still on, her rouge was still on, there wasn't a sign of a burn on her. And she obviously died of asphyxiation. Dr. Neal and George Miller, who was the chief resident at that time, was now identified. Next slide. Now this is the ward I was telling you about up on the top of the D building. You see that we can take care of 30 patients in here. Now here are all the medical insurance because this is where most of the lung burns went. Next slide. Next slide. I swear that's Charlie Davis. Yeah? That's Charlie Davis. Maybe you were taking that. These are mostly medical. These are the chest burns, whereas the lung burns. Next slide. And you see there's the Cocoanut Grove now, the fire's out. See, all of them were still intact. Next slide. Ceilings haven't collapsed. They thought that the floor of the dance floor had collapsed, or it hadn't collapsed. Next slide. And here's the side of the shop house. The windows now punched out. The building is still intact. Next slide. This should be upside down. I guess you can't change it. This is Phyllis Atkins. I'll just show you a few slides. You're going to see a lot more of them. This is the last person to die. She was number 491. This is the night she came in. You see they're all head burns, lung burns, face burns, hand burns. Next slide. This is Vera Daniels, and this is some attempt to do the Massachusetts general treatment, which in those days was pressure dressing with war going into some other solution with Dr. Canada's navigating with not actually very good dressing. So here's the massive face burn, head burns, Vera Daniels. She was the hat check girl, very loved by everyone. Dr. Lund operated on her, I guess, 10 or 15 times. Next slide. And this is some of the burns on the lake. The women's have, they survived. The women had more burns than the men because their clothes were so inflammable that they burned right off. A lot of latent body burns. Mentioned this months later when she came rewrapped and so forth. She recovered. Next slide. This is William Shea, that bartender you saw before. These are pictures of Dr. Lund's collection. This is William Shea, the 19, and again he had lots of face burns. Again, there's Vaseline dressing on the face. Next slide.
He died, correct?
Huh?
He died?
Yes.
Yeah.
This is, I'm sorry, that's Dressler. I mean, Dreyfus. Beg your pardon, that was Dr. Dreyfus, one of our interns. Here he is at the burns recovered. He was just a face burn. Face and hands. Next slide. Here he is about a couple months later. His hands were all healed. His face was white instead they died with the fire. Next slide. This is Gordon Bennett. This is the man we talked about in the class meeting. George Cruz, Stan, myself. There were a lot of our class here in interns in Boston State Hospital. Once in surgery. He was on the football captain. Didn't be a smoker drink. We went to the nightclub that night. This was his fiancée because he was celebrating another friend's first-year wedding anniversary. I don't know whether he shielded his wife or not. I do know that he got out of the fire, and he thought she was inside. He went back in to get her. And the ironic part of that, she was outside. She escaped all her. So he was about 95% burned. They brought him, as I said, over and laid on the grounds over here. He was brought back into the hospital. One half of his body was treated with tannic acid, the other half of his body was treated with animal dyes. He died about Sunday morning, Sunday afternoon, about 3 o'clock, 4 o'clock. It was following a lot of good. Next slide. This is William Shea, the bartender. He gave us a face burn. Next slide. But as the months and weeks went by, he was a massive burn, a very heavy individual, and he died about 2 months later of infection. Next slide. This is Mr. Shea again. Next slide. This is Jeanette Mullen, was treated on the third surgery service. Here's the animal dye. This is where it worked. When it worked well, it was beautiful. Here you see the dye on the S-scar. Gradually gave removing, leaving the skin below with nice granulation tissue. Next slide. A couple months later, now she's ready for skin grafting. She survived the fire with about 30% burn. Next slide. Here is Clifford Johnson. You should probably hear more about the other people. This is the Coast Guard one. Within 6 times to bring out people. 6 times it didn't make it. They often doubt whether he had it's often doubted whether he had a major burn or not. Well, here's some of his pictures. He was about 65 to 70% burn. At that time, he was probably the largest burn that ever had survived. Next slide. Here's some of his pictures. Body burns. These are real burns. Next slide. Next slide. Dr. Lund, and particularly Dr. Browder, Luke Browder, was the one that bulldozed this man into survival. I think it only takes a guy like Browder to do it. You have to know Dr. Browder to realize what his personality was. Every second word was a curse word. had surgery, I won't go any more of that. He did wonderful care of this man. Browbeaten, found him working. And all the skin was all covered with, you wouldn't believe it today, but how we had to cover skin then. You did it with a little tiny pinch. You put a needle in the skin, lifted up a little piece of skin, put it on the burn, you did that maybe 5,000 grafts on the back. Then you put a dressing on it. You know, I remember doing it the next day, going out, and the nurse saying, well, Dr. Byrne, I changed the dressing this morning. You know, you take the dip, everyone was gone, 5,000 grafts gone. That's what happened. That's what happened to this young man on one occasion. Robert had his back completely finished. But then he turned him over on the side, somewhere along the next 2 days later, they turned him back again. Every graft he put on disappeared to have something muscle all over. Here he is about July. See, all the burns are down here. He's heard that tremendous factors. He's got osteo down here. He received a little bit of penicillin. Next slide. Next slide, please. Now he's getting up, you see, he's imagine how painful this was. He was on codeine for about 3 months and we got an ultra battle with codeine addiction. But he's covered. Next slide. And here he is on the anniversary of the fire, leaving the Boston City Hospital for the first time. 2 nurses does not know. He went back to the public health hospital for about another year, then went back to Missouri, came back for a reunion, met one of our city hospital nurses and married her, and then went back to Missouri. 10 years later, while he was coming back from the farm, his truck overturned and he was burned to death. Most ironic tragedy of all time. Next slide. Well, the aftermath of the fire, here's the boy who was supposed to set the fire, Thomas Savage. He really probably didn't. They think it was a faulty light connection. And the guy who was probably responsible for most of the next slide was Arnie Walensky. He had underworld connections. He was the owner of the nightclub. He's the one that filed 1,000 people where only 400 were supposed to be. He's the one that saw to it the electric wiring was all done by an electrician. It wasn't a master electrician. He got it done that way because we had a master electrician. He was going to have to get a permit. He knew he wouldn't get a permit for it, but he said, don't worry about anything. I'm a good friend of Mayor Tobin. And that didn't help Mayor Tobin very much either. And a lot of other things he did wrong. After the fire, they went underneath. This is all prevented with book. I didn't realize that. He had a vault, and in that vault there, I don't know how many thousands and thousands of bottles of whiskey, which he had stashed away down there. Never paid taxes on it. Nobody knew he had it, so that's another count they got him on. Eventually, they got him on the count of about 10 indictments for lifetime in jail, never to appear again. 2 years later, he did get freed, but he only because of terminal carcinoma. He died of cancer about 2 months after that. As he said often, he wished he died during the fire. Thank you.
Thank you, Dr. Byrne. Just one small detail. One of the only people to survive the inferno of the Melody Lounge was a young Boston University medical student named Daniel Weiss. He was moonlighting in his, he was Barney Wolanski's nephew, and he was moonlighting in order to put himself through medical school at that point. And the way he survived was that when all panic and pandemonium began, he lied down on the floor, took a damp bar rag and covered his face with it and waited it out. Because as Dr. Byrne said, things happened very quickly. The fireball passed through very quickly. After it passed, he was able to get up and work his way out of the hospital. Daniel Weiss, when he finished at BU Medical School, did his internship here at Boston City Hospital. I should also mention that we have, it was to me a surprise, and we're actually very honored to have this surprise. Dr. Bradford Cannon, who did much of the burn work at Mass General with Dr. Cope, has joined us for today. The next speaker will be Dr. George Clues, who is familiar to many of us here at City Hospital. Now at the New England Deaconess Hospital, but he's here quite frequently working with City Hospital surgeons. He will discuss the surface, management of surface burns at Boston City.
Ladies and gentlemen, it's a pleasure to be here. It's nice to be a member of the class and have distinguished colleagues who all took part in the Cocoanut Grove fire, Jack Byrne and Stan Levinson, who was always a one-upman man, I've never seen a better entry stand anywhere. We had all graduated the year before and had finished internships here. And it so happened that I was the resident in charge of the burn service at the time that this occurred. I was Charlie Lund's right-hand man, and he was the real hero of this whole thing because he had organized a burn service and he did push it through. But the other heroes have already been mentioned. They were the people who did the business of taking care of these very sick people. Charlie Davison in particular, and Stan Levinson worked with Charlie at that time in the Thorndike. Now I got to correct one or two things. Actually, Dr. Lund had gone home. He was not in the hospital. I arrived on the scene and was immediately put in charge of the burn service as it came. Well, I didn't really know quite what to do, so we got started upstairs in the operating room because it was thought at that time that you had to wash off all burns and then put dressing on them. Dr. Koch later disabused us of that idea with his studies subsequently. I called up Dr. Churchill over at the Massachusetts General and said, Dr. Churchill, at the present time we've had 200 or more admissions and about half of them are alive. Do you think it would be possible for you to take any more people? And he said, no, we're absolutely filled. I didn't ask any more questions. And then his parting shot was, George, keep your head. So I kept my head. And all kinds of wonderful people came in off the street, people wearing uniforms and had never seen the city hospital before, who were commanders and lieutenant commanders in the Navy service. So we put them all to work with what facilities we had, cleaning off these patients and putting on blue dye or whatever was happening. It turned out that at that time, Dr. Lund and I had been working on the use of tannic acid to see if there was, combined with silver nitrate, to see if we could make a better escar that would be less permeable to bacteria and water and so on. Well, it actually wasn't as good as the blue dye. And to summarize the story, that night we ran out of silver nitrate and tannic acid, and so we just began sloshing blue dye on everybody, and everything got treated that way. Jack has shown you some of the cases I was going to show, but there isn't time to take them out, so we'll quickly run through and just look at some of the things that were done. Now, one of the horrible features of this was that about halfway through that night, I came downstairs and bodies were stacked on either side of the main hall of the old Axton floor, which is now on the bottom of the Dowling, which you remember. And occasionally as you went along this thing, someone would wiggle in one of those piles. So he'd be pulled out and something would be done about it. And most of those people were dead. However, we've been given the statistics. Can we go ahead? These are those old glass slides. Actually, that group that were made that Dr. Burns showed you were made as we made ward rounds doing dressings on these people, which went on.
They won't work good. I didn't like the word.
All right, fine, just forget it.
One by one.
No, it's not that important. I think that you've seen the main issues. I can tell you about it. I think the slides that Dr. Burns showed you told the story very well. But in essence, what happened was that we kept putting the blue dye on and doing what we called repairing the escar as it sloughed off or it broke down. And then we would have to cut areas off and let infections out. But it became quite apparent later on that if you had a deep burn, a third-degree burn, that it would not separate. and you had to get it off somehow, and we resorted to using ointment over these things or wet dressings. And that was a very tiresome business, especially for the poor patients. Now, to summarize what we learned, in that combination of some 75 patients that were selected out of the Cocoanut Grove group and 75 others that we had treated in that same year, we came to the conclusion that it took about 2 weeks for a second-degree burn to heal, and it didn't make much difference what you put on it. On the other hand, the tannic acid escars required something like nearly 2 months to separate and to be ready to granulate. And they almost all had infections involved in them. The same thing was true of the triple dye, but it took even longer to separate. And the use of ointment, which was boric ointment or Vaseline, was used, and that had a much shorter time, somewhere in the range of 6 or 7 weeks. Now, what I had hoped to do was to show you a little bit of what modern surgery has adapted from this treatment. It's very impressive now to see how good the skin grafting is, and how the expanded graft with the little holes cut in it so that it spreads out. It'll cover a large area, and then the cells proliferate across the interstices. We started to do that. We were cutting little holes in our grafts. I think it was actually Brad Callan who told us to do that. And I went over to the general to see what was going on. We looked at some of his skin grafting. And then the other thing was excision of grafts. You may have noticed that the burn on the surface of that woman's hand, it was a very lumpy, scarred thing, and yet that wasn't a very big burn. It was covered with these little pinch grafts. And here she had a thick scar on the back of the hand that probably kept it from being pushed. The modern business of excising burns, especially third-degree burns, and putting on a graft immediately stemmed directly from an understanding that came from that. So this was what we learned out of the surface treatment. I was going to say a little bit of a further word about the faces. These people mostly had second-degree burns in their faces. Almost all of them healed. I don't remember any that needed grafting. Now, they got well relatively quickly, but they had these great wound faces with thick lips, like the case that Dr. Byrne showed you. And we had to do a tremendous number of tracheostomies because of the injury to the pharynx. I don't remember how many there were, but we were doing them on the wards with rotten light and having a terrible time doing it. But we got through. Now, as far as Gordy Bennett was concerned, he, like many other people, fundamentally died of his lung injury. He actually never regained consciousness. I think that he probably had carbon monoxide poisoning when he finished his grade. But we bronchoscoped him 3 times, and each time we moved a cast from his trachea of junk, black stuff. And he then died, I think it was 2.5 days later. Yeah. Now, his surface burns were not his problem. I mean, they were not all that bad. They were big, but they weren't bad. Now, Stan Levinson, I'm sure, is going to tell you something about fluid balance problems. And all I can say is that when we correlated the second-degree burn surface area to the fluid requirements and the rise of hematocrit and the fall of it when you reinfuse saline, it turned out that there was a very close correlation to area. This did not obtain nearly as accurately as the third-degree burners. Well, these are the things that were learned, but the encouraging thing is to see what's being accomplished today. My colleague colleague Erwin Hirsch over here has got some really remarkable cases of excision and early rehabilitation instead of the kind of story that we have that went on for 6 months, a year, 2 years before a person could get back on the firing line. Again, it's a pleasure to be here. Thank you for inviting me.
Stop for a minute. Those who have to leave could take this opportunity, particularly the intern applicants. I think a tour guide is going to need you, unless you're very
Our next speaker will be Dr. Oliver Cope, who worked at the Massachusetts General during the Coconut Grove experience. His work on management of burn therapy far preceded the Coconut Grove experience. And in a certain sense, he's the grand master of burn therapy. We're very honored to have him today, Dr. Oliver Cope.
Sad moment in certain ways, but a tremendous delight to be here, not only to Max Finland, but to Charlie Lund, particularly. As a medical student, as I came into medical school, he began from one time after another to do special things for students. It was marvelous. I welcome so to be here, to do it honor as I can. You had here at this hospital a very numerically an enormous problem compared with what we had faced at the MGH. The MGH had a different idea about the management of a disaster. And I'm going to give you just a word of how that came about. When I was a fourth-year student in the medical school in February of 1928, I was walking down the corridor in the MGH, and an internist friend said, "Well, aren't you going to into surgery? What are you doing here? Get down to the emergency ward quickly and see what's going on." And I went down, and there were 31 seriously burning patients that had just come in by ambulance from the Beacon Oil disaster in Everett. They were all bad. There'd been an explosion in the Beacon Oil, and they were badly burned. Our emergency ward was pandemonium. In the morning, I went in. There was a dressing room with a bathtub in it, right near the entrance. And I went in there to see what was going on. And there, 2 interns were debriding the areas, and the nurse with a big syringe was sweating him with tannic acid. Now, tannic acid came out of Detroit in 1926, 2 years before. It was very convincing. But here was a man groaning under the tannic acid, squirting it over his back, and his bloods were being denuded. I stood it and went down the corridor to the 5 emergency rooms where there were patients from various places, and there the same thing was being done by 2 or 3 or 4 people. All the nurses, all the medical students, all the house officers available were down there trying to denude the patient and patients and put tannic acid. I wandered from one to another and saw that they hardly knew what they were doing. None of the patients were receiving fluid therapy. The treatment of the burns had taken everybody's attention. I went back to the room near the entrance and looked in. And while I came, the man died. The first patient I'd ever seen been present when the patient died. Unforgettable. Unforgettable for an attention to the wrong thing. Clearly. Now the mortality in that group of 31 was 50, certainly more than 50%. It's hard to imagine that that's 28, and there was the neglect of the attention to fluid therapy, the surgeon's absorption with the wound. I sort of thought that over a little bit. It was a extraordinary surprise, and got to see, I happened to see various people who had a minor burn. One, a niece in 1935, after I graduated and been through my residency, and was a staff member, and she had upset, she was 3 years old, and had upset the coffee pot on her hand. And I heard her screaming when my sister called me, but she couldn't find the doctor father. So I grabbed a lot of Western ointment and some sterile things and went out. And I told her to put the hand in the cold water. It was February. And I got out, instead of a screaming child, there she had her hand in a nice big yellow bowl, and had the cold water running into it, and she was sitting on the kitchen sink, perfectly contented with her legs over, and her mother was reading. That was an immediate difference from the pain of those men that I saw in our emergency ward in 1928. Can't be denied. And I had an opportunity, by the way, this hand, I did it up in Greece, and put pressure on it, recommended by the physiologist in Chicago. Until now, too much edema to her. And she had an uncovered arm when the water went over her arm. And therefore, it was going to, although it had been a coffee pot, it didn't stay there. She had a sleeve over it. The water would have stayed in contact with the skin for longer. And one could predict that it was going to be, ought to be a superficial burn. At any rate, I wrapped it up. And of course, it was the wrong thing to do. And her father was at lunch at the Harvard Club with some other doctors at a meeting, and told how I just wrapped it up. And my God, the result was a consultation the next morning with Dr. Churchill. And he kept wanting to do the bandage and look at the thing, and I wouldn't let him, because the thing to do was to keep it sterile. One of the blebs must have ruptured because it was moist up here at the top of the dressing. But at any rate, it was a little battle, and I won the battle. I insisted I wouldn't let him look at it. And we got outside, and he said, Dr. Oliver, you ought to can that. Well, I was sure enough from the few observations I made that it should remain sterile, because after all, there was nothing in the coffee, no bugs in the coffee, and no bugs in Belmont water, and it would be pretty good. Well, I wouldn't be telling you the story if you can't see any scar. And it was a big event in the family. However, the opportunity came to do this with several and many patients before Pearl Harbor. Pearl Harbor, you remember, with the major injuries were burns, both in the naval personnel and in the non-military people. And the hospitals were absolutely overloaded, swamped. Isidore Rabin when I was the chairman of a small committee thrown out to Pearl Harbor right after the disaster to see what had gone on medically. Came back, I happened to have reason to know Isidore Rafton, and he asked me for various reasons to come to a meeting 1 month later, January 7th. And I had outlined to this committee at the National Research Council the idea that in a disaster, you have to be sure you're doing the right thing first. Clearly, the experience in disaster burns, in my view, and what was it in Pearl Harbor, there were sometimes patients didn't get attended to for 36 hours and longer. There were so many patients and so short in the number of trained personnel, nurses, doctors, to take care of them. Well, I suggested at that meeting on January 7th that we turn the thing around a little and be careful not to pay too much attention to the burn wound and pay attention to keeping the patient alive and taking care of the other things that you are going to cover. I went home to back up to Boston from the National Research Council with a stipend to test out the idea of what would be left uncared for if we just, in a disaster, covered the wounds quickly with Vaseline, some dressing of that sort, put on pressure dressings where they could be done, and care for the rest of the body. Keep the patient alive, pay attention to the fluid needs, of course, and then we looked at the wound. Now, Dr. Cannon, there were several others who were involved. Dr. Cannon looked into what tannic acid and the triple dyes did compared to Vaseline in a wound. And this time, and I want to hear it, he'll tell you. But roughly, a standard wound made by a plastic surgeon to get off graft, if it takes 8 days to heal under the Vaseline, it takes double that time to heal under tannic acid and 3 times under that time, 30 days, under the triple dyes. Both triple dyes and tannic acid and substances like it injure the wound further. That's why the patient has pain. And it's something that we thought ought to be considered. Then there was the question of infection. Just a few years before Pearl Harbor, one of our gynecologically minded surgeons treated a patient with bad burns by giving them what the English started with sulfonylamides in an ointment and covered extensive burns with a sulfonilamide mixture, and he died of kidney shutdown, of poisoning from too much absorption. Perfectly clear that if you put something in the burn surface, if it doesn't grab hold of the tissue there, it will get sore, and he was poisoned by too much absorption. So one knew that the surface container should not be containing the drugs. The drugs ought to be given inside, and we measured, among other things, our pre-requisite in the infection part, measured the piling up of drug sulfonilamide in the blood fluid. And if you give it into the patient's mouth or by intravenous, it very soon amounts in the blood fluid. So the burn wound itself is getting the chemotherapy. Things like that were studied very carefully. At any rate, we were reporting this study to the National Research Council, which was the objective to get some kind of a measure. And in just a week, 8 days before the Cocoanut Grove disaster, a woman came in with a 50% body burn, and she was treated by the short surface treatment and care of her bodily needs. And we called the entire East Surgical, this is a hospital endeavor, by the way, all the time since January 7th of 42. We called the entire East Surgical Service to come and see the treatment of this patient. The hospital as a whole, surgical service and the medical service too, agreed that this would be the therapy, so that we could test it. And they looked at it and went on. There were several older surgeons who didn't think this was an adequate treatment. But when the Saturday night came, the East Surgical Service was on service that night. So that when the emergency call came, the service that had seen that other patient, that had accepted that this was going to be the treatment, was initiated from the beginning. And then the West Surgical Service, who'd been off duty at the time, came in and helped out with it. We didn't pay nearly enough attention, of course, to the carbon monoxide poisoning. The patients all that came to us, of the 114, all but 39 were dead within 3 hours, and they died of pulmonary injury. And the medical service, of course, had come to our rescue when we hadn't paid it, hadn't thought about it. And you know that you didn't mention this, again, the attention to the other things. In 1929, there was a terrible disaster from X-ray in Cleveland Clinic. A fire broke out in the basement of the Cleveland Clinic Hospital, and that's where the X-rays were stored. And the air conditioning of the time took the smoke from the basement and blew it around up through the other floors. And how many died? 30-some, more than that, more than 30 died. And it was, what was the poison? Phosgene, right. And the Kodak company had immediately to withdraw all the X-rays. They had a new kind of X-ray coming, and you'll remember that most hospitals put their stored X-rays out in case there was a fire, put it out in the courtyard, and took it out of the inside of the hospital. Now, it was rumored later that the furniture of the Cocoanut Grove had been covered by the old X-ray. Now, the Kodak company had how many million worth of old film? They were going to just destroy it. They sold it to some of it to furniture manufacturers. And so here was another complication. It was unanticipated, unattended to at the time. So our urging is that attention be paid to we mustn't lose out by paying excessive attention to the wound in a disaster. And this is not easy, of course, unless we can think. We were urged to get on by the National Research Council, and this book was published in June of that year. It was the issue of the Annals of Surgery at the request of the National Research Council and the Armed Services. And actually, this book was printed in 4 editions and served for the recommendations of the armed services throughout the Second World War. Now, your experience is you were overloaded in an extraordinary way, and how you managed to just you've given us a herd thing, and there's never a time like this when one doesn't learn something one way or another from it. I think again of Charlie Lund and all that he did for me personally, and I thank you for allowing us and asking us to come.
Institute. He's the first surgeon ever appointed to the Thorndike in late November of that year. However, he developed immediately gastroenteritis. And as house services lived in the hospital at that time, he was placed into a hospital bed and sat there until Saturday night, November 28th. On that night, someone came to his bed and said, "Get up, you have work to do." The person who was the burn fellow at the Thorndike at that time is now currently the head of the burn unit at Jacobi Hospital, Dr. Stanley Levinson.
Thank you very much. First, I want to apologize for being late. We had a little snow in New York. It didn't seem much to me, but it was enough to have the flight delayed for 2 hours at LaGuardia Airport. Second reason why I didn't want to precede Dr. Cope is Dr. Cope's been my teacher for almost a half century. And I think you can see what an exciting time it is to have Dr. Cope as a teacher. Also, I'm really thrilled that Dr. Finland is here. All of us, everybody, owes so much to him. Now, I want to begin by reading something from the May 25th, 85 issue of Lancet, because it typifies what the Boston City Hospital, and particularly the 2nd and 4th Medical Service, and especially the Thorndike, was like in those days, and why it was possible, as Dr. Cope ended his talk, for so much to be learned when faced with this disaster. This is a report of a talk that was given at the 50th anniversary of the Hammersmith Hospital. And the address was given by Sir Christopher Booth, who at that time was director of the MRC Clinical Research Center there. And he said the following: Hammersmith had been, as Richard Crossman once said on a visit to the Secretary of State, a triumph of the human spirit over adversity. It was a place where there was always a fizz of excitement that gave a champagne quality to every day. Some years ago, a Swedish visiting professor to the Department of Medicine wrote afterwards to say that it had never been anywhere where there was such a glow of enthusiasm for clinical research. Yet, accustomed as he was to Sweden's immaculate clinical facilities, he could only bewail the fact that the work had to be done in such inadequate surroundings. Well, that was the Boston City Hospital. But most importantly, the people there. And I want to show you just a couple of pictures of people that you've all heard about, but I don't know whether you have seen. Well, that's obviously a picture of Dr. Finland there on the left with his colleague, Dr. Casso, who preceded him as the director of the Thorndike. Next, please. And we have missed one slide there, I'm sorry. Could you go back to the very first slide? Well, maybe I forgot to put it in. If so, I apologize. It was a picture of Dr. Peabody and Dr. Minot. Dr. Peabody, as you know, was the first director of the Thorndike, and Minot the next, succeeded by Casso, and then Dr. Finland. Well, this is a picture you've seen, but I put it on again, not to talk about the surface burn per se, but Mr. Johnson typified almost every problem of the burn patient. He had severe hemoglobinemia, hemoglobinuria, non-oliguric renal failure. He developed an anemia rapidly, and Dr. Haleham and Dr. Suchu Chen at the Thorndike studied the anemia of burns and made the observation of the marked change in osmotic fragility of the red cell, which began almost immediately after the burn and persisted until, obviously, the cells that had been damaged were destroyed. In addition, Johnson had very severe respiratory tract injury. Now, if you think of how you take care of patients now with respiratory problems, ARDS or other problems, you have endotracheal tubes, you have blood gases, you have people with special training, etc. None of that was available. There were no respirators. Can you imagine taking care of the patients you take care of now without respirators, without endotracheal tubes? And I think it's really remarkable as we look back that in view of those instrumental deficiencies, that as much could be done for these patients as was done. On the other hand, Dr. Byrne mentioned that Clifford Johnson lost consciousness. And I want to show the next slide. Dr. Finland, who immediately took charge of the whole respiratory problem of these patients, and obviously you don't dissociate the respiratory from the rest of the patient, but asked us and insisted almost within the first day to go around to every single living patient in the hospital and find out where they were at the time of the fire, what they did, and whether they lost consciousness or not. And Charlie Davidson and I, George and others went around getting this information. But it was Dr. Finland who made us get it. And the point is, if you look there, you can see lots of areas in which there's a black bottom. That means the patient lost consciousness. Well, why was that important to find out? Next, please. Turns out, and this is from really a classic paper, again, of Dr. Finland's, Dr. Davidson and I helped him with, but it was his paper, which is in Medicine in 1946, I think. If you look at the severity of respiratory involvement, 0 to 4, among those patients who did not lose consciousness, 2/3 of them either had no evidence of respiratory tract injury or at the most very mild. In contrast, among those who lost consciousness, 2/3 of them had very severe respiratory tract injury. And I'm sure you all know now, if that's one of the clues immediately that you have to go by if you have a patient who's in a room with a fire or anywhere. Has the patient lost consciousness? If they have, your chances of having severe respiratory tract injury, beyond just upper airway damage, is very high indeed. Next, please. Now, Dr. Byrne showed you the admission film of Phyllis Atkin. This is pictured of her somewhat later. The upper left was actually about 12 days after the injury. So her burn of the face was largely, almost completely second degree. But you can see from the roundness of her face, and then on the bottom picture on the left, her breasts and so forth, she was an extremely well-nourished young woman. I think she was about 19 at the time. The pictures on the right are her, but about 8 weeks later. And it's obvious that she had lost a tremendous amount of weight. I'm not sure how well it shows up, but her scapula, which is in the back, are protruding, beginning to protrude through. Her clavicles are evident. And in her hand and forearm, the granulations are edematous. And that's what you see in a malnourished patient. Now, but about shortly before the Cocoanut Grove fire in the late 1930s, next please. Well, this is just to show you in contrast what healthy granulation tissue looks like on the upper left there. Next please. This is a picture of Sir David Cuthbertson. He was a physician, but who had just gone to a hospital in Scotland in charge of the laboratories. But he didn't want to just sit in the laboratory doing routine analyses, and he began to study the metabolic problems of patients with injury. And he described very quickly the marked change, particularly in protein metabolism and in energy metabolism, which was characterized by an increase in metabolic rate and an increased urinary excretion of nitrogen. Next, please. And just to typify this was not his study, but one here, of a young man with a very minor burn, really 15% body surface. The way this is plotted is food intake nitrogen from the 0 line down, fecal nitrogen, so this is nitrogen intake, fecal nitrogen here, and that's perfectly normal. But the increased urinary nitrogen excretion, and this is the cumulative negative nitrogen balance, and then the patient goes into equilibrium, then analysis. Well, this is a minor injury, relatively, and a modest loss. But that could go up, instead of a loss of 150 grams of nitrogen, it could go up to 4 or 5 times that much. Next, please. And it was known that it was modulated not only by the caloric intake, but by the protein intake, so that if no protein was given, the negative nitrogen balance was considerably greater than if, on an isocaloric diet, a 1.5 grams of protein per kilo was given. So it was known at the time that these patients needed special feeding, special attention. Next, please. And this is a picture that all of you would know from the Henderson-Hasselbalch equation. But he was professor of biochemistry at Harvard, and I remember he gave us a talk in biochemistry in college on how to take care of the sick and injured patient. And his recipe was to meet their nutritional needs, you get a good French cook. Well, we had no French cooks at the Boston City Hospital. Next, please. And this is Dr. Lund again, but I've shown it here particularly because Dr. Lund was always interested in nutritional problems, and he came up with the idea, well, since we don't have a French cook, but we do have something like a Waring blender, we can make liquid diets. And in these patients, and for the patients studied thereafter, liquid diets have played an enormous role. It was also recognized, though, that for many of the patients, they couldn't be fed enterally, or they couldn't be fed enough enterally. Next, please. And this is to remind you that the first reported study, at least, of trying to infuse nutrients intravenously was by Sir Christopher Wren in the 17th century. Next, please. But in more modern times, in the years just preceding the Cocoanut Grove fire, that was taken up and advanced to a tremendous degree by Robert Ellman, who was then a surgeon at in St. Louis. And he was a good friend of Dr. Lund's. And here at the City Hospital, at the time of the Cocoanut Grove fire, intravenous feeding was done, just as you do it now, although not through this intravenous catheter. Next, please. But in addition, and Dr. Cope, I know, will be pleased to see this picture of Dr. Fuller Albright, because as probably all of you know, Dr. Cope was the surgeon who worked with Dr. Albright in their remarkable studies of patients with parathyroid disease. But in addition to his studies of calcium metabolism and renal problems, Dr. Albright studied the use of plasma intravenously and studied its metabolic fate. And based in part on that knowledge, plasma was also used for nutritional purposes, that is, to increase the plasma albumin in these patients. Now, next, please. Now, all that was put together in the treatment of Clifford Johnson. So he got liquid diets enterally, he got amino acids, glucose, electrolytes intravenously, and he got plasma, and he got red cells when he was anemic, but not when he was not. And
The only picture basically you haven't seen here is the upper right after his back was covered. You can see the tremendous weight loss of this young man. He developed a decubitus there on the left thigh with the bone sticking out, but he then, as you can see, went on and finally recovered. And in no small part because of the nutritional care. Next, please. Now I put this slide up because I'm only going to take another minute or so to recall to you, because you're all here at the City Hospital, one of the other really remarkable studies done at the Boston City Hospital, not related to the Cocoanut Grove fire per se. This is to remind you of the classic slide of Dr. Lobach, who was professor of pathology at the Harvard Medical School in 1926, when he studied the effect of scurvy on wound healing, and was able to demonstrate that in the absence of vitamin C, you did not get collagen. It wasn't known that it was collagen at that time. He called it intercellular material. But you did get it as soon as you gave ascorbic acid. You got a boost feeding collagen. Well, Dr. Lund here at the Boston City Hospital carried out with Dr. Dill and a surgical resident, Crandon, a classic study on vitamin C deficiency, on scurvy, produced experimentally in a human volunteer. Now, the apocryphal story, of course, is that for Crandon to become scorbutic, all he had to do was to eat every meal in this cafeteria. That study, by the way, is published in the New England Journal of Medicine, and you really ought to look it up because it's something that all of us associated with the City Hospital really are very proud of, because it's a fantastic study. Well, Dr. Lund, because of his interest in vitamin C, got Dr. Robert Johnson, another classmate of ours, who was then at the Harvard Fatigue Lab, to begin to study vitamin metabolism in the burn patient. Next, please. I'm going to just show one slide here that this is a patient with a fairly severe third-degree burn, and down below is indicated the intake of ascorbic acid. And you see most of it was given intramuscularly, so it's not a question of lack of absorption. As you know, the recommended daily dose for a young, healthy individual would be somewhere between 25 and 40 milligrams a day. This patient is getting as much as close to 750 milligrams or a gram a day. In other words, 20 times the normal. And despite that, you can see the plasma ascorbic acid gets down to 0. And then if you did at that time what's called an ascorbic acid tolerance test, you could show that they acted biochemically as if they were scorbutic. It was only when given 2 grams a day, which is almost the total body store that each of us had, 2 grams a day, the plasma levels began to come up to normal. And then later it was shown that this biochemical scurvy that developed also means physiologic scurvy if you look in terms of resistance to infection or wound healing. So that then led to the use of increased doses, not just of ascorbic acid, but also the B vitamins and more recently the A vitamins. Well, again, I really appreciate, Dr. Spohr, that we all have this opportunity to be here, and we're going to be followed by...
Thank you. Our next speaker will be Dr. Charles Davidson.
Came on, but wasn't a classmate of all these people here. I came on from California and have been here about a year, a little over a year, and sitting at a table. We used to have breakfast and dinner down here, and lunch too, and sitting at a table right about there one morning at breakfast, Carlton Chapman said, he was there at the same time, he said, Charlie, I think you think you're going back to California next year. I don't think so. I think you'll be here the rest of your life. Exactly right. Here I am, back at the city hospital, same old room, same old place. But a lot has happened in the meantime. That night, 43 years ago, I was on the town. I was fortunately not at the Cocoanut Grove, out with some friends, and we heard sirens and fire engines and ambulances. I came back to the city hospital and walked down the basement corridor toward the Dowling building, and the first person I saw was Lasky Taylor, who's not been mentioned, biochemist working in the Thorndike at that time, and he was there getting medical students or anyone he could, including himself, to shake plasma. The plasma over in the Mallory was frozen plasma, and it takes a lot of heat to thaw frozen plasma. Somebody hadn't thought of that little problem. Well, very shortly after that, I ran into Dr. Finland, and he and Dr. Levinson and Dr. Clues and others, but really Dr. Finland, Dr. Levinson, and myself made ward rounds, as has already been said. We make ward rounds 24 hours a day for, I think, 3 or 4 days without any sleep at all, because by the time you got finished with going around and seeing all the patients, you had to start in again because there were critical things that needed to be taken care of. A lot has been said today. I'm not going to take very much longer, but I have a few things that I'd like to say. What did I learn? What did we learn from this? We learned, of course, a lot about the treatment of burns and so forth. We've heard a great deal about that. You can read about it in the literature. But there's some other things that I think we learned, or maybe haven't entirely learned yet. One of them was that we didn't take time off. It was taking care of the patients that we had to do 24 hours a day, and there wasn't any time off. We didn't think about those things, and that's what medical care, I guess, is. The care of patients came first. I learned a great deal about nutrition. It became a hobby of mine for the rest of my life, still is, and Stanley taught me a great deal about the problems of nutrition, and Dr. Lund and others. I learned a great deal about the pulmonary complications of burns from Dr. Finland. We spent hours putting x-rays up and trying to figure out what was going on, because in addition to the severe burns of the upper respiratory tract, there were burns, or there was something going on lower down. And Dr. Finland pointed this out very early, and put these films up. He'd show us little areas of emphysema, because the small bronchioles had been closed, and the air trapped behind them in little areas of emphysema. And so there were the late complicated respiratory complications, so well described in the paper of Dr. Finland's, which you certainly should read at that time. Well, that was another thing we learned. And I suppose that paper in the New England Journal last week that George or somebody referred to you must have got that started, Dr. Spar. At any rate, it certainly did say a few things. And in the beginning of that paper on burns, which I recommend that everyone, whether you're interested in burns or not, read it. It's a medical progress a week ago in the New England Journal by Dr. Robert Demling, Longwood Area Burn and Trauma Center. I didn't know there was such. How ignorant I am. And he's in charge of that. He notes that the United States still has the highest incidence of burns of any industrialized country. We have a lot of burns still in this country. He goes into some of the epidemiology of burns. The peak incidence of burns is not in old people in nursing homes. The peak incidence of burns is in age 0 to about 4 or 5 years, and they're mostly scalds. Now, there must be some way of preventing children, so many children, from becoming scalded. And there's a lot more. I suppose the non-inflammable children's clothing has reduced the incidence of flash burns and fires, but structural fires account in hotels, rooming houses, and so forth, account for about more than 45% of burn-related deaths, whether it's due to the burn or to respiratory or other complications. Liver complications, I've always been interested in liver disease. Tannic acid was supposed to be bad for the liver. One of the things, most remarkable things, was the autopsy on Mr. Shea, the bartender, who was a large, obese gentleman, possibly enjoying a little bit of what was behind the bar. At any rate, his liver weighed 4,000 grams. It was just chock full of fat. I don't think that had anything to do with burns. New York Times, a couple of days ago, had a small paper pointing in the front page, pointing out that hospitals were not prepared around the New York area for, it was the anniversary of the Bhopal disaster, were not prepared for a disaster, a chemical disaster. Are we really prepared here at the BCH and other places for a disaster of various kinds? What about disaster drills? What about the prevention of burns? Shouldn't we be on the preventing side? I wondered as we all came in here and the chairs were very close and it was very difficult to get in. Suppose that Pepsi machine caught on fire. How quickly could we all get out of it? Well, we have to think about that kind of thing as well as the actual medical treatment, which I was going to go into a little more. We have to be prepared for disaster, but how much can we prepare? And this is a very complex question that I certainly don't want to get into, but it is something that I'm sure you have a disaster plan. But does everybody know the disaster plan? Does everybody know how to get in touch with everybody else and get them in and so forth? And know what to do and where to go, and so that the thing runs smoothly. I think this is still very, very important. And of course, lastly, the greatest threat of all, as far as our livelihood is concerned, and particularly of burns, is the possibility of nuclear war. And this probably has been called by Howard Hyatt the last epidemic. And we have to spend a little of our time thinking about the political and social side of the possibility of nuclear war, which would certainly be, Fred Aykroyd, when he came back from Vietnam, pointed out to me that one of the disasters, he was there as a surgeon, that he learned a great deal. Well, it seems like a poor way to have to learn, but disasters such as the Cocoanut Grove and so forth, we all learned a great deal. But I think we have to pay attention to prevention, and we as physicians have to be, who see these things, have to be on the side of prevention as well as treatment.
Dispense with the talk I was going to do on the neuropsychiatric complications. Those of you interested can come talk to me afterwards. We have a presentation by Dr. Hirsch.
Thank you. I'm delighted that the medical service of this institution put up some excellent surgical grounds. About a year ago, Basil Pruitt, who is the director of the Army Burn Institute in San Antonio, Texas, gave a speech at the Scholar Ratio of Trauma, which is sort of a very important presentation in the annual meeting of the American College of Surgeons. And he postulated that the burn patient be the international trauma model. I think those of you who listen to these very exciting presentations today will agree that the lessons that were learned in the management of the burn patients of the Cocoanut Grove fire vastly exceeded just the management of burn patients. They addressed surgical physiology, they addressed pre- and post-operative care, and perhaps simply addressed the management of trauma overall. And there are probably thousands upon thousands of patients in the world who owe their lives today to the efforts of Dr. Finland and this very, very distinguished surgical faculty that we have here today that will be the envy of a great number of teaching institutions in the United States. Having said that, some of you may be wondering what the picture is back there. For the medical residents, I can tell you it's not going to stay here. About a year ago, a young artist that lives here in the neighborhood sketched this view of the old and the new Boston City Hospital, and then proceeded to color it. And some of us saw it and became very interested, liked it very much. And Dr. Cohen and others suggested that perhaps it would be a very nice gesture to award, if that's the right word, each of the participants of today's symposium with a copy of this print of the Boston City Hospital. Having said that, of course, the artist doesn't work 24 hours a day, neither makes rounds for 3 days in a row. So the presentation, the individual prints will be sent by mail later on, but I thought it would be nice for some of you who have not seen this, and those who participate here to see what in the next few weeks will arrive by mail. On behalf of Dean Sanson, who could not be here, the Commission of Health and Hospitals, and the staff of the Boston City Hospital, I'd like to thank Dr. Finland for his, I don't know how many years of work and support of this institution, and this absolutely outstanding faculty here today that provided such much quality information. Thank you very much.